Good evening all. Today's topic is from concept to clinic. The breakthrough insulin co-formulation. Seasonal financial disclosure. Today's agenda is divided into two parts. Part 1 is comprehensive solution and part 2 is practical considerations regarding the co-formulation. Only one co-formulation works co-formulation insulin is insulin degraded aspart. Coming to the first note, the considerations are lower hypoglycemia, meantime flexibility, ease of use, convenience of device, better quality of life, cost effectiveness, efficacy. Is either gas a prudent choice? Yes. Coming to the insulin degraded aspart, the world's only co-formulation insulin. It is insulin degraded aspart is a soluble combination of two individual analogs. It contains alpha long-acting degraded 70% and short-acting aspart 30%. In the pharmacological combination, insulin aspart elutes almost as hexamers and insulin degraded elutes as dihexamers. Insulin degraded and insulin aspart do not interact in the solution and in the subcutaneous tissue, thereby retaining their individual properties. One is short acting, one is ultra long acting insulins. So coming to the idea, world's only co-formulation insulin. The most crucial Indian realities of diabetes management are: one is high carbohydrate diet and high postprandial glucose levels, and patients uncontrolled on multiple oral antidiabetic agents and need for safety and convenience. And insulin degraded aspart is the only solution at present. Adding gas in the subcutaneous depot, when given subcutaneously, insulin degraded aspart divides and dissociates. First, insulin aspart rapidly dissociates in the subcutaneous into monomers and released into the capillaries blood and regulates the post-meal glucose. And insulin degraded slowly dissociates and maintains the prandial glucose levels. So it's a basal insulin with a built-in a rapid acting component for a basal. Coming to the idle gas versus insulin larger. The meta-analysis of randomized controlled trials was on safety. Regarding safety, efficacy outcome, meta-analysis of mean glycosylated hemoglobin, that is HbA1c, fasting plasma glucose, and 9-point self-measured plasma glucose end of the trial. And safety outcome is meta-analysis of confirmed hypoglycemia and non-confirmed hypoglycemia. The inclusion criteria in this meta-analysis are randomized control trials, for the technical field. The inclusion criteria are randomized control trials, insulin degraded aspart, intervention, and insulin labs in 100 units per ml or 300 units per ml control, and type 2 diabetes participants, adults with an HbA1c of 7 to 11%, and the sample size of study shall not be less than 20. The exclusion criteria are the non-randomized controlled trials, duplicate articles, individual case reports, and studies with no available data. The efficacy of glycemic control unable to determine the trials. Diabetes with other diseases such as type 1 diabetes mellitus, secondary diabetes, cardiac disease, bad liver or severe renal disease. These are the exclusion criteria for this meta-analysis. Coming to the safety, idle gas versus insulin larger. Meta-analysis of randomized controlled trials. The safety, lower nocturnal confirmed hypoglycemia with ida gas compared to eye-glass is great, and superior mean HbA1c control with ida gas compared to the insulin glargine in end of the trial analysis. So this proves ida gas significantly decreases the mean HbA1c with lower nocturnal confirmed hypoglycemia when compared to the insulin glargine. And coming to the mean and flexibility, we are discussing one by one. So, mean and flexibility. The mean and meal related flexibility. The people traveling across time zones and shift workers, those who rely on healthcare providers to administer their insulin during home visit, they face problems with the insulins for regular taking. So, the ida gas can be taken at any time of the day with major meal, that is contains high carbohydrate meal of the day, either with breakfast or lunch or with dinner. And flexibility in the dosing. So, coming to the flexibility, insulin glargine U100, it should be initiated with 10 units once a day. It should be taken any time of the day, but at same time every day. Coming to the insulin glargine U300, initiate with 0.2 units per kg once a day within 3 hours before or after the usual injection time. So, coming to the ida gas, initiate with 10 units of once a day, administer with any major meals of the day, because it contains ultra long acting basal insulin degludec, which maintains the glucose levels. The RST Clinical Practice Recommendation 2022 is ease of use, challenges of basal plus or basal bolus insulin regimen. Basal bolus insulin regimen or basal plus is a complex regimen and different titration schedules for individual components, and needs 2 insulin pens and 2 insulin pens. Persistent monitoring can be painful and expensive. So, RST clinical practice recommendations for the management of T2DM 2022 as compared to basal plus and basal bolus, along with similar efficacy and lower rate of hypoglycemia, ida gas provides simple to administer, convenience of one insulin kit and one pen, requires less dose. Convenience with ida gas. Thus, start with an insulin that fits into the lifestyle of the patient, providing convenience with lesser number of injections. Coming to the basal plus, requires 2 injections, one is basal and one is bolus, 2 injections. Coming to the ida gas, once a day, and it contains both basal and bolus insulin, degludec and asthma. Coming to the basal bolus, 1 basal and 2 bolus shots. And coming to the ida gas BD, only 2 injections for morning and evening, or 2 major meals of the carbohydrate meals of the day. And coming to the quality of life, patient reported attitude, practice, satisfaction and quality of life on ida gas. A single center trial is conducted with adult type 2 individuals on ida gas from January 2017 to December 2020. 245 participants' data analyzed, and 26 questions in the questionnaire, and number of the questions with points, and the scale used is Likert scale. The questionnaire contains demographic information, duration of insulin, diabetes status and initiation of insulin, current diabetes and ida gas use status, ease of use and quality of life, missed insulin dose, weight gain since insulin start, frequency of blood sugar monitoring, includes all. Coming to the quality of life on ida gas, 89.8% reported improved quality of life with a reduced stress, and 86.7% found it comfortable to inject ida gas in different social situations, and 94.2% could manage their day-to-day activities better after initiating ida gas. Coming to the cost effectiveness analysis, a post-hoc analysis of ARISE study. Cost of the control of ida gas compared to all other treatments for achieving HbA1c levels below 7%. Then there are two bar diagrams given. For all treatments, it costs around 17,59,587 rupees. And coming to the Ida gas, it costs around 8,58,128. So in the Indian cohort, Ida gas was found to be associated with a lower annual cost of control compared to all other treatments for achieving HbA1c levels below 7% by 8,58,128 versus 17,59,587. Coming to the cost of control of Ida gas compared to all other treatments for achieving individual treatment targets, yearly cost of control comparisons are: in the Indian cohort, Ida gas was found to associate with a lower annual cost of control compared to all other treatments for achieving individualized treatment targets 8,03,931 versus 23,64,445 rupees. So that's difference. Coming to the efficacy point, efficacy by prior treatment subgroups. Arise India study results are: adults with T2DM 185 patients were selected. The study was conducted from 0 weeks to 26 to 36 weeks. Ida gas as per local practice. So from the baseline to end of the study. So on OID is only 9.8% to 1.9% reduction A1C, basal only 10.1 to 2.1% reduction of A1C, and GLP-1 receptor agonist 9.1 to 1.7% reduction, and basal plus basal bolus to 9.5 to 1% reduction, premix 9.7 to 0.9. So the change in HbA1c from baseline. So coming to the second agenda, the practical considerations. Ida gas. How to initiate? Administer the Ida gas with the largest meal of the day. Initiate 10 units Ida gas body with the most carbohydrate heavy meal of the day. Administer Ida gas twice a day with the two most carbohydrate heavy meals of the day. Meal size and postprandial glucose response should dictate the ratio of the two doses, which doesn't have to be 1:1 split. How to intensify? Intensification from Ida gas once a day to twice a day. Main meal concept. Main meal concept is not the major portion of the meal. The carbohydrate content is the main part. The main meal concept, here there are two diagrams. So 50 grams carbohydrate first meal, 30 grams carbohydrate, 100 grams carbohydrate meal. So 100 grams carbohydrate is the major meal. So we start with once a day with 100 grams carbohydrate meal. When it should be intensified to twice a day, we should give a 50 grams of carbohydrate meal and 100 grams of carbohydrate meal. How to intensify? Intensification from Ida gas once a day to twice a day. When to intensify? When the postprandial glucose excursions after 2 meals in 1 week and excursions unresponsive to diet manipulations, and once a day exceeds more than 30 to 40 units per day. So the total daily dose split over 2 meals with greatest carbohydrate content ratio based on the relative carbohydrate content in postprandial glucose excursions. So switching from Ida gas from other insulin regimens, switch from basal and basal bolus insulins. From basal insulin once a day or twice a day, same basal dose, that is same dose of Ida gas once a day or twice a day should be given. And twice daily, that is 1 basal plus 1 bolus. Same basal dose should be maintained with the Ida gas once a day. Thrice daily, that is basal, 1 basal and 2 bolus. Same basal dose and insulin taken as per BAD. And 4 to 5 times daily, that is basal plus bolus. Same basal dose, either Ida gas BAD or 2 shots of 2 bolus insulin, insulin aspart, and 1 shot of insulin dendritic aspart. So switching to Ida gas from other insulin regimens, that is switch from premix insulins. Premix once a day is 1:1. Dose split over main meals. Ida gas as once a day or twice a day. Premix BAD 1:1. Dose split over main meals twice a day, daily, and pre-mixed daily, same total dose, split over main meals with or without additional insulin as per and gas PID without. So use of gas in special populations like elderly individuals with pituitarium individuals with renal impairment, pituitarium individuals with hepatic impairment, pituitarium individuals with during religious fast, and adult even individuals during. Thank you.